Hi, everyone. This week's content is going to be about medications that indirectly activate monoamine receptors. So that's kind of a long-winded way of saying things that we often refer to as antidepressants, sometimes anti-anxiety medications. So let's proceed here. Let's first start talking about depression and how we treat it. One of the greatest artists of the 19th century, uh, Vincent van Gogh, of course, was really well known for his real struggles with his mood. He's probably more likely had bipolar disorder in addition to seizure disorder and maybe even borderline personality disorder as well as an alcohol use disorder. But this is one of the last paintings he did in his life, and you can just really viscerally feel the weight of a depressive episode in this painting. This is Wheat Field with Crows. And a few years ago, during that tremendous super bloom that we had of wildflowers in California, I was down at the Carrizo Plain, and I was walking around at sunrise and realized that I kind of walked into that painting itself. And so this is sort of in tribute to and with the intention of helping those who suffer with depression. So let's start with getting clear about what depression is. And the good thing is, since we're talking about medications that are often used to treat both depression and anxiety, and the reason for that is probably because these are fairly overlapping conditions. I don't see that many patients that have depression that don't have any anxiety, and I don't see many patients that have had anxiety for a while that aren't struggling with some degree of depression. And so the good news is that many of our medications overlap across these two disease states. A little bit of trivia, but alprazolam or Xanax was originally had been the application to the FDA was as an antidepressant. Even though we think of it as a fairly straightforward anti-anxiety medication, that I think that speaks to sort of how overlapping these two disease states, which are often described as being different, are actually more similar than not. And if you ask 10 different people what causes depression and anxiety, you're probably going to get 10 different answers depending on their perspective. And if you're familiar with the old parable of the blind man and the elephant, you know that all the blind men are feeling different parts of the elephant and are quite convinced of the truth of their explanation. The person holding the tail thinks it's a rope. The person touching the tusks thinks it's a spear. And the problem is they're only seeing a portion of the big picture. And of course, we see this in depression. We see different forms of explaining this depending on one's perspective. If somebody who's a psychotherapist might see a more relational etiology, somebody who's more of a biological psychiatrist might see a biological or an inflammatory disorder. Somebody who has a more holistic view might see food issues or allergies. So there's lots of different ways of describing depression, and they all probably hold some degree of validity. And there's nothing that says we can't treat multiple etiologies. But this being a biological psychiatry, psychopharmacology course, that's what I'm going to focus on today. So there are a lot of different moderators and causes of depression. We know that there is definitely genetic heritability of depression. We know that there are these epigenetic factors, things that can be passed down from generation to generation through epigenetic uh, changes. And then there's this large component of environmental factors, and that may be everything from adverse childhood experiences to malnutrition to systemic forces that are at play that increase inequity in populations. But they all may have these sort of final common pathways of disrupting different biological systems, everything from glutamate to inflammatory cytokines to monoamines, which is mostly what we've focused on in our biological psychiatry for the last 50 years, although that is starting to change as we're looking more at things like glutamate dysfunction that we'll be talking about in subsequent lectures. These all may sort of have this confluence into decreased neuroplasticity, increased cell death, and that may ultimately result in the phenotype of a depressive disorder. Now, the the discouraging thing about this is that there are obviously lots of different things going on here. So there isn't one single thing that we can go after. The good thing is it's also a target-rich environment. There's lots of different ways that we can approach this problem here. And so, here's some examples. When it comes to glutamate, we're looking at things like esketamine and ketamine, dextromethorphan. Some of the inflammatory cytokines might be able to be mitigated through wellness activities such as exercise, diet, meditation, being connected to a larger group of people, improving sleep. There are certainly things that we can do at a population level to try and decrease the burden of depression. So the point here is there are lots of different things that we can probably do to attack the problem of depression. So historically, the way we have addressed most of our antidepressant, anti-anxiety approaches have been to either, in the case of anxiety with benzodiazepines, we modulate GABA signaling, but most of this sort of the monoaminergic approaches have involved approaching dopamine, norepinephrine, or serotonin, which we've talked about in previous lectures about how those play a part. And so we have these different drug groups that look at these different monoamines, and we'll review those today. So it's important to remember, said this earlier, but I think it's worth saying again, that we don't have depression because we're short on serotonin. We get depression. Depression is no more caused by a reduction in serotonin than headaches are caused by a depletion of aspirin from our bodies. That's not to say that serotonergic approaches don't affect depression. They do, but that's not the cause of depression. Just in the same way that we can treat a headache with an aspirin, even though aspirin deficiency is not the cause of a headache. So remember, it is this sort of slow-moving process of neuroplasticity that happens with most of these medications, which takes 3 to 4 or 5, 6 weeks to occur. And we're changing that first messenger at the synapse, increasing the amount of serotonin, for example, or dopamine or norepinephrine, causing that signaling to occur across the synapse. That causes these intracellular changes. Obviously, this is grossly oversimplified, releasing things such as brain-derived neurotrophic factor, that activating things like TRKB receptors, which changes genetic expression, and then eventually we get this increased neuronal growth and decreased apoptosis, or programmed cell death. And that ultimately allows for this phenotypic change in the condition, which correlates with this neuroplasticity. Now, let's take a look at these indirect monoamine agonists and where they work, because they do a couple of different things. So they block SSRI. So SSRIs will block the serotonin transporter or the serotonin reuptake pump at both the axon and at the dendrites. So upstream and also downstream. So that's going to do a couple of different things, and we can see from this diagram from the stall text what's going on here. So we have this, so by the medication blocking those serotonin transporters, we have a net increase in serotonin at these different sites. So at both the synapse and upstream at the dendrites. What's going to happen over a while is that we're going to have desensitization of these, what are called serotonin 1A autoreceptors. So if you remember, autoreceptors are on there kind of to be like a thermostat. So they tell they signal that there's enough of whatever it is in the synapse to stop releasing it. So these autoreceptors become desensitized with this increase in availability of serotonin. And without that ability to shut itself off, because we've now inactivated, desensitized those autoreceptors, we now get more serotonin being released at the other end on the down the axon. So what that's going to do, so then shifting our attention now to the synapse on the right of these diagrams, is that we see this increased amount of serotonin at the synapse is actually going to cause those postsynaptic receptors to downregulate. So because there is because of this increased serotonergic tone at the synapse, those receptors on the postsynaptic side they're going to withdraw into the membrane, and we're going to have this downregulation of postsynaptic serotonin receptors. So when it comes to talking to patients about these medications, it's really important to understand that they're a little backwards. And I've used that term with patients. I say, they're a little back asswards, that you're going to get side effects before you get benefits of the drug. And I know that makes no sense because, if you told me, hey, I have a headache today, and you said, I have something for you, but it'll take 3 to 6 weeks to work and you're going to get side effects before you feel any better, I'd probably be kind of underwhelmed. But unfortunately, that's been the state for the most part for the last 40 years or so with most of the medications, actually longer than 40 years, more like 60 years, 70 years. It takes a while in order to get these therapeutic effects, but you're going to get side effects at the beginning. The good news is that side effects tend to drop off as time goes on. There are some side effects that will linger, such as sexual dysfunction for some people. Some people that also goes away. But for the most part, these side effects will abate with time, usually around the time the medication is starting to be noticed. I say, the worst of the side effects are usually in the first week or so. Now, you may have patients that will tell you a few days after starting this medication that they're starting to feel better. That may be a placebo effect. I don't really care. If somebody's feeling better, they're feeling better, and that's what's important. And so if somebody comes to me after a week and says, hey, I'm feeling better, as long as I'm sure they're not getting manic and they're still sleeping okay, I'm great with that. I'm not going to discourage that. I'm not going to explain it away. And we have to also remember that all drugs have side effects. So as much as we would love to have a medication with no side effects, such a thing doesn't exist. And so it's important to understand that in order to get these therapeutic effects, we have to deal with some side effects. And that's just sort of the cost of doing business here. A reminder, there are 3 hurdles to getting to medication success. And the goal really, ideally, is remission. We don't always get there, but it's kind of like the North Star. We keep pointing ourselves in that general direction, and we keep making that our goal. The first thing is tolerability. Can they take the medication without feeling sick? If they feel sick every time they take it, they're probably not going to take it anymore. So we usually know that pretty quickly. And you want to ideally build in some kind of structure when you start a medication that somebody can reach you if they don't feel well after starting the medication, either from side effects or from unexpected adverse events like they can't sleep or they start feeling suicidal thoughts or they start feeling mania, that they have some means of getting in touch with you so you can head that one off at the pass. This is also when some of the more transient side effects show up, such as GI distress and headache. Sometimes anxiety can show up in the first few days of an SSRI. And then usually by the time we schedule the next visit, which is probably going to be about a month out, we're hopefully starting to see a little bit of benefit from the medication, what we would call a response. They're not fully well, maybe they're 25% better or something like that. That would be great. And we might start seeing some of these more delayed side effects. So if the medication causes weight gain, we might start seeing that. We might start seeing that sexual dysfunction starting around this time as well. And then finally, remission. So what we might need to do at the period where if we're getting a response, I generally will say either let's stay the course a little bit longer at the same dose, or let's think about increasing the dose if the person is tolerating it. If they've had no response at 4 weeks, 4 to 6 weeks, I generally will switch to a different agent because, 2 times 0 is still 0. So if you're not getting any movement at the sort of 4 to 6 week mark, I would suggest changing medications at that point. And then finally, we want to keep moving towards that remission point. We may not fully ever get there, but we want to try and make that our goal. And that might require increasing the doses or augmenting the medication, which we'll talk about later in this talk. Now, some people will debate this with me, but the question of, is there a best antidepressant? And the answer is really not really. They're all relatively equally effective. There was some attempts to try and parse this out a little bit. Andrea Cipriani did this paper a while back, comparing both efficacy and tolerability. So this is one of those forest plots, remember? So anything anything to the right of the line here favors the drug over placebo. So the more you are to the right, the more it favors the drug. So based on efficacy, she said amitriptyline was the most effective drug. Which is interesting. This is an older tricyclic antidepressant, generally with a lot of side effects. And then she also looked at tolerability. So anything towards the right tends to be more favorable. Anything towards the left tends to have more side effects. So let's look at a few different drugs here. So escitalopram, Lexapro, common drug. I use it a lot. I like it. Modestly effective, quite tolerable. A drug like fluoxetine, plain old common Prozac, also reported as being quite tolerable, but maybe less effective. I think these are fairly marginal differences, so I wouldn't get too caught up in their rank order. If you take a look at that forest plot, you'll see they line up pretty similarly. So that's where we get this idea that they're all relatively similarly effective. A drug like mirtazapine, quite effective, moderately tolerable, probably because of the sedation and appetite increase effects that happen. So we're always balancing this sort of calculus of efficacy and tolerability. And that's partly what's going to go into the art of practice, is thinking about how can we use side effects to our advantage. So a drug like mirtazapine, which can be quite sedating, can be very useful for a patient who's having trouble with sleep. Then finally, a drug like paroxetine, which I have no love for, they thought was modestly effective, modestly tolerable. My personal clinical experience with paroxetine would put it further down the list, but this is where the data landed. Okay, some quick reference cards. These are getting a little outdated because they're about 10 years old. I would love to say that we have tons of new antidepressants since then, but we really don't. So these are reasonable little reference cards that you can print out from CLE if you like, that look at things like weight change and cost, which is probably the most outdated part because some of these drugs are now generic, like escitalopram and venlafaxine, which they weren't at the time of the publication of this. And also looking at common concerns like sexual dysfunction, sleep, etc. All right, so kind of repeating what was said earlier, but really I just want to reiterate that if you're not getting any benefit after a reasonable trial, don't keep chasing after something that isn't working, because it's not likely to continue working just at a higher dose. Unless for some reason the dose was very small, like, sometimes we'll inherit a patient who was started on a very low dose of something like 10 milligrams of fluoxetine from a primary care provider, and they haven't seen much benefit. And in that case, I'd probably go to 20 and then wait a period of time and reassess. So this is your sort of menu of options here. These are all monoaminergic, it's a mouthful, drugs, with the exception of things that work on glutamate there. So the SSRIs, the SNRIs, the tricyclic antidepressants, which arguably are also serotonin and norepinephrine reuptake inhibitors, although they are less selective. There's the atypical antidepressants such as mirtazapine. There's norepinephrine reuptake inhibitors such as bupropion, the old MAOIs, and we'll go through these individually.